Okay, very warm good morning to who all to all of you here. And this IC will be dealing with a very intriguing topic, which many of us come across in our daily practice. This is the scene where the patient sees nothing and the doctor sees nothing, and traditionally we have been all taught that it could be an RBN. So we are looking at the other causes too, which may be too subtle, or which may be missed, or which may be mistaken, or which may remain mysterious. So only after ruling out all this should we actually seriously be thinking about a functional visual loss, which again the onus of proving it is with us clinicians. We cannot label a patient as having functional visual loss without proving it. So this is an all-in-one course that will deal with all aspects of suspected functional visual loss, and I have with me my very eminent co-instructors. We have Dr. Rohit Saxena, Professor and Head of Pediatric Ophthalmology from RP Center AIMS as the keynote speaker. Dr. Marine Paul, from Medical Director, Trinity Eye Hospital, Thrissur. Dr. Natasha, Professor and Senior Retinal Specialist, Amrita Institute. And Dr. Nina, HOD, Pediatric Ophthalmology and Strabismus, Giridhara Institute, Kochi. So I hope by the end of this course, when we write eyes WNL, we would be very confidently saying that it means eyes within normal limits and not that we never looked there. So thank you, and I invite Dr. Marin for her talk on anterior segment finds in cases of suspected.
Good morning, everyone. Yes. Good morning, and I will be talking to you on easily missed anterior segment abnormalities which cause diminution of vision in patients, both adult and pediatric. At the outset, thank you, Dr. Lathika, for having me here. This is by no means a completely comprehensive list of all these abnormalities which can be missed, but I'll try to go through what are more important. So modern ophthalmology focuses on visual quality and not just visual acuity. Now we are all familiar with this picture, and we know that anything in the visual axis, any obstruction in the visual axis can cause diminution of vision. Now, when you talk about pediatric cases are much more difficult to assess, and the most commonly missed ones are usually refractive errors, especially those which deal with problems of accommodation and also amblyopia. If it is not a total cataract, it can again be very easily missed unless you do a dilated examination in pediatric cases. Congenital glaucoma, again, you need to have a good degree of suspicion to come to the proper diagnosis. Now, coming to adults, I'm not dealing much with the pediatric because it's a very, very vast topic. Now, we'll discuss this according to the structures anterior to posterior. In the cornea, dry eye is usually the most commonest cause of unexplained, where your examination is there and you see there's nothing, like Lathika said, patient is not seeing properly, you are also not seeing properly. Why? This is because that dry eye can be a complex clinico-pathological entity. It involves the tear film, the lacrimal glands, eyelids, and the ocular surface cells. And dry eye patients lose vision faster between blinks than patients without dry eye. So they will not be able to give you even a clear history as to what is the problem. They'll say that there is blurring, but it is like intermittent. This is because the rate of visual acuity decay between blinks is much higher in dry eye patients. So in addition to a T-BUT and Shermer that we do routinely, these tests as well may help you to come to a proper diagnosis. Now the next frequently missed thing is a transparent foreign body. Regular foreign bodies you will see. There are a couple of cases, interesting case reports. Now this one was from the Postgraduate Institute, Chandigarh. This patient was seen in a couple of centers and it was missed. But actually what was that there was a transparent foreign body. Is there a pointer? Okay. there was a transparent foreign body, a plastic piece which got embedded in the in the superficial stroma, and an ASOCT showed the hyperreflective reflexes, and this was removed, and it was a diagnostic challenge. There's another report from China where a patient went for an MRI and said that the patient has a diminution of vision following an MRI. There was no history of trauma, and what actually happened was that on a second examination, they found that there was a small corneal scar. Is there a pointer, please? So there you can see that there was a small corneal scar, and when on repeated inquiry, they said that there was a history of trauma 15 years back. And when they did the MRI, this embedded foreign body in the angle got disturbed and led to a bleeder here, which led to the diminution of vision. And on further examination, they found that there is evidence of siderosis as well. Now, early keratoconus, especially those patients who are keratoconus suspects or subclinical keratoconus, can be easily missed. Also, the other eye in a formiformistic keratoconus also can be a diagnostic challenge. So, in addition to a pachymetry and curvature-based video keratography and ocular surface scanning, you can also do elevation-based topographies now with the slit scanning techniques and the Scheimpflug imaging, which will give you an idea of the posterior elevation and the posterior curvature of the cornea. We also have instruments to measure the corneal hysteresis, and of course wavefront aberrometry now gives you very, very clear idea on the keratoconus situation of the eye. Now coming to opacities, nebular epithelial opacities, especially in the visual axis, can be, they can be very subtle, and unless you do a proper slit lamp examination, can be missed. Dystrophies, of course, early stages can be a diagnostic challenge. I'll talk a little more about it a little later. Now coming to decimate folds, especially though in these areas we have something called as the calotropis, which the sap of which can enter the eye and cause decimate folds, which can be subtle, and the eye will be very quiet. So we have to actively elicit a history of working in the fields, etc. Now coming to a post-refractive case, the patient has undergone a refractive surgery, has gone home happily, and comes back a week later with complaint of decreasing vision. A proper examination will reveal to you that there can be a few multifocal PMNL infiltrates at the flap interface, which is a sterile inflammation, and an ASOCT will help you in coming to a proper diagnosis of DL. Coming to corneal dystrophies, epithelial corneal dystrophies by nature normally do not give you a lot of, in the early stages, a lot of visual disturbance in the early stages. But stromal and endothelial dystrophies can present in the early stages as well with visual problems. And in Fuchs dystrophy, in addition to a proper slit lamp examination, you will have to do a pachymetry, a specular microscopy, and an ASOCT to establish the diagnosis in the early stages. Now coming to ICE, and especially in this, the Chandler syndrome can present as a diagnostic challenge. So what in the early stages, the eye looks like this, very, very quiet. But unless patient will come and complaining about intermittent visual disturbances, and at that stage, if you do a gonioscopy, you will find this peripheral anterior synechiae. It will eventually progress to a full-blown corneal edema. And these are usually seen in middle-aged women and as an unilateral case of blurred vision, and only a careful examination will reveal these corneal guttatae, endothelial guttatae, and will progress to corneal edema and stromal iris atrophy and all the associated symptoms. It has been postulated that HSV and Epstein viruses are implicated in these cases. Now coming to the anterior chamber, multiple causes can cause diminution of vision, of course, which are like intermittent, especially a narrow angle glaucoma, both primary and secondary in the early stages. You have to have a high degree of suspicion. You have to do a proper slit lamp examination, in not only like just a Van Herrick's, a gonioscopy, an UBM, and an ASOCT will help you in these cases. History of drug intake, especially topiramate and similarly related drugs, can precipitate acute myopia and shallow chambers. Now, we are all familiar with uveitis, which looks like this, which is very, very angry, and the eye looks red. But not all uveitis are like this. There can be subtle uveitis, especially when you're dealing with viral anterior uveitis, which are caused by either all these viruses. Only a careful examination will reveal a granulomatous cluster of small or medium-sized KPs in the Arls triangle. Posner-Schwarzman syndrome and Fuchs uveitis syndrome also can present as very, very quiet eyes. So one examination point which you can look for, especially in CMV, if you're suspecting a CMV uveitis, is that the endothelial cell counts of the affected eye usually is lesser than that of the fellow eye. But definitive diagnosis, you require a polymerase chain reaction or a Goldman-Whitner assay. Now, coming to the lens, metabolic disorders are one of the commonest causes for sudden diminution of vision. Of course, most likely uncontrolled diabetes. So, a full, complete blood workup has to be done before we say that the eye is perfectly normal and there is no, cause for diminution of vision in the eye itself. So, diabetes is one of the most commonest causes for an unexplained diminution of vision. Now, I'll talk a little more in detail about dysfunctional lens syndrome. So, dysfunctional lens syndrome is not actually a new diagnosis or a diagnosis of of examination. It is more of a diagnosis of investigations. Now, it has come about because we have much more investigations in place. So, it has been now currently staged into 3. In the early stages, there is loss of near vision and development of higher order aberrations. In the second stage, there is a decrease in the contrast and night vision. And finally, it becomes a full cataract, and it affects your color perception, and you can easily diagnose it as a cataract. Now, so DLS is basically a spectrum which starts from presbyopia and progresses on to cataract. Similarly, in the lens, congenital or traumatic subluxations, especially if they are of only 1 or 2 clock hours, can be easily missed and require a dilated visual dilated examination to come to the diagnosis. Now, we have done a good cataract surgery. Patient is happy. Patient has gone back. Say a couple of months later, comes back complaining of glare and near vision problems. You have to dilate the patient. A cursory examination on the slit lamp in an undilated pupil, you may miss a subtle PCO. So these have to be dilated and checked properly, and you will see that this thing is there. So thank you so much. I have not covered pupil because that will be covered in detail by Dr. Lathika. So these are, like I said, the basic. I've just touched on the basic diagnoses which you should keep in mind when you are facing a diagnostic challenge in a apparently quiet eye. Thank you.
Thank you so much, Dr. Marin, for that very practical presentation. Now I call upon Dr. Natasha for her talk on macular mysteries that may be leading to the suspected cases of unexplained functional visual loss.
Good morning to all. So we'll just look at some of the subtle things that we see in the macula that may be missed on a cursory examination, which can give you a clue why the patient is complaining of defective vision and you're not seeing anything. So this patient had the vision reduced to 612, few microaneurysms at the macula. It was not involving the fovea, and the OCT also did not show much edema corresponding to the 612 vision. But the fluorescein angiogram gave us the answer. You can see that in the area of the clustering of the microaneurysms, if you can you see that the capillary network is broken there? It's a small tributary vein occlusion that looked like mild diabetic retinopathy. So that is what can happen. Tributary vein occlusions may not produce much of edema, but they will produce severe ischemia with loss of the capillary zone. And if it's at the fovea, for sure the visual acuity will be affected. So that is something you can, if you find something in the fundus and you are not able to explain, a fluorescein angiogram can help you. This patient, you can see, again, it looks fairly, just a few RP changes kind of thing at the fovea, and you can't really explain why there is decrease in vision. If you look very carefully, you can see that there is a neovascularization in the infratemporal area, which means that the patients had an infratemporal branch vein occlusion earlier, which has caused the foveal changes, and that is why the patient has a decrease in visual acuity. This patient underwent sectoral PRP. An old BRVO, you must understand that sometimes they go unnoticed by the patient, and you have to look for telltale signs, especially when you're looking for a difference in visual acuity that you cannot explain. Look at the change in caliber between the superior arcade and the inferior arcade. That can tell you there will be, or some subtle sheathing, some retinal pigment epithelial changes at the fovea. Disc collaterals are a good clue. Of course, neovascularization is like a kind of a definite clue that in that quadrant there was old vein occlusion. If you find pigment clumping like this, always be wary. It need not always be pigment clumping. It can be just a perifoveal whitening. You can see that in the perifoveal area, here there is a whitening. This perifoveal whitening or that pigment clumping is very diagnostic of juxtafoveal telangiectasia. So you can see the leaking juxtafoveal vessels on a fluorescein angiogram, and in the OCT you will get tissue loss, you will get the classical ILM drape sign. And it's very important to recognize this, because although we don't have much treatment for it except in the stage 5 where there is neovascularization, this will change the prognosis of the patient when you find it out. It is prevalent among diabetics, and the OCT is very diagnostic. And if you see this round and red lesion in the fundus, you should not be misled thinking it is normal. Definitely it's a macular hole. So again, sometimes it can be missed on your indirect ophthalmoscopy. You need a 90D or a 78D to recognize it, especially the small ones. It occurs due to tangential traction by the vitreous. The longer the duration, the poorer the vision and the recovery. Smaller the hole, it is the better. Of course, OCT will give you the diagnosis. Here, this is post-macular hole surgery. If you find something wrinkling there, again, it will be very subtle, just a glistening that you see when you're examining the macula, and it is an epiretinal membrane, shiny glistening appearance. Sometimes tortuosity, sometimes straightening of the vessels can occur, depending on which direction the pull is. And long-standing, it can cause cystoid changes, and it is better when it is treated early. Of course, in this stage, it's very easy to recognize. But in the first picture, if you saw, it is more difficult to recognize. This is post-op. We'll just rush through all that. Yeah, again, vitreomacular traction again will occur as just a kind of glistening there, and it can appear as cystoid edema. You may mistake it for cystoid edema unless you do an OCT. And again, you should remember that it is one of the subtypes of diabetic macular edema, which should not be treated by injection. So OCT will give you the answer. And if you see like this, sometimes what will happen is you will see a lot of drusens. Most old people have drusens, and you may think that the visual acuity is not explainable because the drusen is not affecting the fovea. But always drusen means dry AMD. Dry AMD means atrophy. So atrophy will be there in the macula. That could explain why the patient has a decreased visual acuity. So even if they are not involving the fovea as such, do an OCT, and that will give you the answer that there is amount of foveal atrophy there. That is causing the decrease in vision. And it can slowly progress to geographic atrophy. PCV, when it's subtle, it's a little difficult to recognize. You can see the orange-red lesion there. But here, of course, the exudates are here. Suppose we saw this patient before these exudates came. Sometimes you will miss this orange-red lesion, which is the PCV that is there. That is the polyp. And again, you will get the answer with the ICG and the FFA. Post-operative patients who are complaining of decrease in vision, and you're looking at the fovea, it looks clinically normal. Take your 90D out, have a look. Are you looking at cystoid macular edema? And again, fluorescein angiogram can help you delineate it. Well, in a diabetic patient who's complaining, diabetic retinopathy he has, who's having CME, you don't know whether it is CSME or it is a pseudophakic CME. The investigation that you can do is a fluorescein angiogram and look for a disc leak. When you have a disc leak, it is a pseudophakic CME, otherwise it is a CSME. Why is it important to differentiate? Because you can treat pseudophakic CME with steroids, posterior subtenon or intravitreal, and the other one will require better to be treated by anti-VEGF. Then this patient, 618, left eye, diabetic since 15 years. On the examination, it looks like a severe NPDR. You did an OCT, there is no edema on the OCT. So how do you explain the 618? Again, it is fluorescein angiogram that gives you the answer. There is a lot of disruption of the foveal avascular zone, so it is macular ischemia. So macular ischemia need not produce edema. It will just go on to atrophy later on. So it can be recognized only, of course, now you have the OCTA that will help you. You don't have to do the invasive one, but in a severe NPDR, of course, a wide field angiography is better anyway, so that you don't miss out any peripheral NVE also. Again, CSR sometimes can be written off as a change in refraction because they will produce a hypermetropic change in refraction, and the defective vision is not so much. So if you don't look carefully at the fovea, you will miss that blister and you will give a change of glasses and send the patient off. And again, smokestack leak you can see. Chronic CSR is more difficult to find out because it will be just seen as diffuse retinal pigment epithelial changes. Your AF will give you a good idea because AF will show extensive RPE atrophy, and this track is very important. This is the AF picture, you can see that there is what you didn't really see on the fundus picture, you can see on the autofluorescence better. And this track, if you see, clinically you may be able to recognize that track, which means that the patients had recurrent attacks of CSR. A foveal blister that can be very easily missed is a PED. And if it's at the fovea, if it is involving the foveal avascular zone, it will definitely cause a decrease in vision. So a good history of a sudden loss in the somewhere along the way, any floaters, any history of injections done somewhere. Many patients will tell you that they've had injections, so then you know that, okay, something was wrong with the retina, or some history of vague near cut, they will say. And a good 90 and 78-day examination. In case of suspicion, do an OCT and a fluorescein angiogram when you want. Beware that macular ischemia can cause decreased vision without edema. Beware of any change in appearance of the fovea. It may be exudates, discoloration, whitening, glistening, change in vessel caliber. In myopes especially, you can do an OCT because myopes, it's very difficult in that tessellated fundus to make out a foveal change. And if you still can't, as an anterior segment surgeon, you can always ask for help from your retinal surgeon. Okay, thank you all for your patient listening.
So that was a wonderful talk. Just one more thing. One thing, that is, we find a lot of RP epitheliitis, not a lot of, but occasionally we've come across RP epitheliitis in young adults coming with defective vision, macula looking more or less normal with slight stippling. So how do you recognize that also? Just one.
Epitheliitis produces very typical features on the OCT. You will be able to see the hyperreflective outer layer in the OCT.
Thank you, Dr. Natasha. After that really quick overview of all the retinal issues that we need to be on the watch out for. Now, our next talk will be by Dr. Lathika, who will talk to us on the leads from the pupil and the optic nerve. So, Dr. Lathika, over to you.
Okay, so I'll be talking about what the optic disc hides and what the optic disc can tell us in cases of suspected functional vision loss. And the scope of this talk will be mainly focusing on the missed, the mistaken, and the mysterious that we come across in the optic nerve pathway. So these cases are often baffling and sometimes referred also. So it's very important not to hurry and not to delegate, because there is no room for error and you're making the patient do many of these tests over and over again. So I'll start right from the history. Just one point in history taking is that your prompters should be very precise, because many of the symptoms in optic nerve disease are quite vague. So unless you have, I'm just putting some examples there only. So unless you ask about each of these specifically, especially even the field defects, they may not come out with these helpful hints. And if a patient talks to you about transient visual loss, then the two important things that you can ask to localize the pathology to the optic disc may be a short duration of the attack. That means less than 15 seconds or so. Then the pathology could be in the disc, and also the precipitating or relieving factors that we are all familiar about in optic neuritis. But you need to ask that, otherwise the patient will not tell you. And any patient with an unexplained visual loss, we are in a hurry to dilate, see the fundus, and look at what is happening there. So it's better to have a checklist in the OPD before you do that, because you cannot come back and do these things reliably. So it is always good to have a checklist with all of these things and make sure that it has been ticked off before you call for dilatation. Now regarding, these are just points I'm picking from our daily OPDs. So regarding color vision, Ishihara is what still we all do in our OPs, but it's a very gross test of color vision. So it is not, especially in the early phase of an optic neuritis, it is just not enough that the patient recognizes colors, but the speed of recognition of colors is also important. Only an experienced refractionist can pick that up. So it's better that you go and do it yourself and see what is happening. So another thing, a very simple thing you can do is the red cap test, where you can show these bottles with red caps in front of the patient's eye simultaneously and ask the patient whether there's a washout or not. So they will very quickly pick it up themselves. Now pupil, of course, is a vital clue. I don't know whether this video will be very, very basic. I have a video on that. Can we? Yes. What's happening?
To check the pupillary reaction, dim the room lights. Ask the patient to look into the distance to relax the accommodation. Make sure that you have a bright flashlight. First of all, assess the size of the pupil and make sure there is no anisocoria either in bright light or in dim light. Next, assess the direct light reflex by shining a bright light into the pupillary area and looking for the briskness of the pupillary reaction in the same eye. Next, for the consensual, you have to throw a bright light into one eye and see for the pupillary reaction in the other eye. You can place a barrier or a hand so that there is no spillover of light from one eye to the next. Also, to aid in better visualization of the pupil, you can use a reflected light in the eye in which the consensual is assessed. So the consensual is seen very clearly by using a reflected light. Next, you should assess the near reflex or accommodation and pupillary constriction during accommodation. Now let's move on to the swinging flashlight test. This is a patient with RAPD in the right eye. So you shine the torch into the normal eye. You can see the pupil constricting briskly. Now swing the light over to the affected eye. You are expecting the pupil to constrict, but here you can see that the pupil is actually stalling and trying to dilate. This process is repeated once or
Okay. So just the things to highlight are, don't go and stand in front of the patient. Let the accommodation relax, and also the light should be dim, but your light should be very bright. And assess each pupil separately before you go on to the rest of the pupil assessments. And nowadays, I personally use a magnifying loupe to assess the pupil. So that is, I think, very helpful for me. So quantification of RAPD, yes, it is important, but it is not as important as detection. So once you detect, your diagnosis is okay. So quantification, of course, you have a grading, but neutral density filters, pupillography, everything is the objective grading. So now we come to certain clinical questions regarding RAPD and its significance. So in patients with defective vision, there is no RAPD. That equate with a healthy optic nerve. Not always. If it is bilateral defective vision, if you're dealing with a bilateral optic neuritis or any of the symmetric optic neuropathies, especially a Leber's, then you may not be, actually RAPD may not be detectable in those cases. Also, if your pupil is already compromised due to a third nerve palsy or a trauma or previous surgery, again you cannot assess an RAPD reliably in such patients. So in bilateral defective vision, what is it that you actually assess? It is the pupil cycle time, which may help you. It is
cycle time is about
nothing
954 milliseconds
throwing
or
a
better.
horizontal,
So here
it's
we
called the
go.
pupil cycle
I'm gonna
edge
take
time,
my
because the
half millimeter
horizontal beam
pipette,
of light
put it
is
right
thrown
on the edge
from
of his
edge to the
pupil,
pupil,
and
and
watch.
100 time required for 100 cycles of constriction and dilatation is known as constriction and dilatation. So it is generally around 840 milliseconds considered normal. Anything above 954 is considered. So that is one thing you can do in a bilateral
Cycle time.
of the pupil. Now I'm going further into the eye, and let's go to the difficult discs, where a green filter evaluation I found very useful in all optic disc assessments. So let's see this clinical scenario where there is an acute onset gross defective vision in one eye, and you see an RAPD. You are expecting the disc to be abnormal, but it is abnormal. RBN I'm not going to talk in detail, because we all think RBN first in this scenario, but I'm going to focus on the significant other, which means first is PION. PION, that's posterior ischemic optic neuropathy. All I want to highlight here is that generally we come across, when we say PION, we think of the arthritic type of PION. After surgery or after trauma, generally after trauma in the ICUs, we see gross defective vision due to a probable PION. But here I'm talking about a PION which is non-arthritic, and the patient can very well walk into your OP with a moderate defective vision and an RAPD and a normal disc. So don't always say think it is RBN. There are some other things also you should be looking at, like for example, this will maybe one word more about PION versus RBN. See, in PION, the visual loss is usually central. And also when you take the VEP, because it's ischemic, it is the amplitude that is down, compared to optic neuritis where it is the VEP latency that is more affected. So and the changes, prognosis wise, it is permanent and irreversible in PION. Okay, so there are, and why should we be aware of this? It's not only for the diagnosis, but the workup and the prognosis is very different. In an optic neuritis, we may have an autoimmune type of battery of investigations, whereas in the other, it is usually a vasculitis we have to exclude, and a complete cardiology evaluation is a must. And prognosis also is very different. So this we'll skip. So an RAPD and a normal disc, what else? It can be any of these in the early stages. All I want to say is it can be a lot of optic neuropathies in the early stages which look rather normal. Only in the late stages they go in for a slightly swollen disc, and then later on to the pale disc. So just because if you find an RAPD and a normal looking disc, at least it is not always an RBN. So that's a take home I was just looking at. And second question is, very often we come across temporal pallor. Temporal pallor just means selective affection of the papillomacular bundle. So is it an ongoing disease? Is it old ischemia? It's for us to distinguish between which is which. So this is a scenario where a 54-year-old man comes to us with a chronic progressive defective vision, 618 OU and a slight cataract. There is no RAPD, but the disc is showing a mild, it is showing a temporal pallor. So our confusion was whether to go ahead with a neurophthal evaluation or do a cataract surgery. So again we looked at so that's when we perused the records, and then found that he was a tobacco alcohol addict. And then we started thinking about this toxic or possibility of a toxic optic neuropathy. The fields came up with a centrocecal, but before labeling, the point is even if there is a centrocecal, before labeling it as a toxic or a nutritional optic neuropathy, even in this patient, it's very important to rule out a compressive optic neuropathy. That is why we have to send for a neuromedicine consultation, and MRI was done, and then the cataract surgery was deferred, and it was a vitamin supplement that was advised by the neurologist. So the point is you have to be very, very diligent in scrutiny of records. In some cases, these are the symptoms that may help you decide whether this patient needs a neuroreferral or not. Now coming to the investigations that can help you, we all rely on perimetry. Most of the time a 30-2 is fine. Just remember that the metabolic causes usually have and the demyelinating ones usually have a central and centrocecal. If you find an altitudinal defect, it's more likely to be an ischemic cause. And if you find hemianopias, it is usually, you have to think high suspicion for compressive lesions or masses behind the optic nerve. Now, VP, as I just mentioned, it is not mandatory in the diagnosis of optic neuropathy. It's useful, but in patients with subclinical findings and medial opacities in infants and such, only in selected cases. And as I said, increased latency, always it is a demyelination that is more likely, and if it's a reduced amplitude of the P100, it is more likely an ischemic episode. Now, neuroimaging is a must. You should not think twice about it if you really feel it is indicated. MRI orbit should be for if you have a suspicion of, that's how we customize. If you really suspect a compressive optic neuropathy, then you go for MRI orbit. If you have a bilateral field defect or atypical optic neuritis, it is MRI brain is a must. In vascular pathologies, angiographs, MR angiography, and now we have we have to categorize demyelinating optic neuritis or immune mediated. A lot of findings are there in the MRI. So anyway, it is an indication. And always communicate with the radiologist for better results. OCT is now coming up in a big way in the follow-up, especially of papilledema and optic neuropathies. You have to, RNFL, the programs are RNFL and ganglion cell analysis. These are the two things we have to look at in following up these patients. Blood, of course, you have to have a CBC. Look at ESR in particular, because a lot of things can lead to inflammatory, infective, all sort of things can be there behind an optic nerve inflammation. Also, the nutritional optic neuropathy needs serum B12 and RBC folate. Technically, we actually don't do it. We go for a clinical examination. And antibodies, as I said, to categorize optic neuritis. Never shy away from consultations. It is always a teamwork. Neurologists, psychiatrists, immunologists, hematologists, internal medicine, the entire battery and the team has to be called in as and when necessary. So in conclusion, the take-homes are to aid your neurophthalmic diagnosis in cases of suspected functional visual loss. Make sure that you have a precise prompters for a productive history. You have a checklist before dilatation. Your pupillary examination is scientific and technically right. Your interpretation of RAPD should be cautious, and in relation to the fields in the disc, you should be diligent and prompt in your investigation, appropriate cross consultations whenever necessary, and always keep an open mind for atypical and early presentations. Thank you very much.
Thank you, Dr. Lathika, for that wonderful talk. Just a couple of points. This is the most difficult part is when you have a person coming to your OPD with maybe 6'9", says there's some blurring, the disc looks slightly pale,
Yes.
and you do your OCT and there is maybe 1 quadrant RNFL thinning, and now you don't know what to do. So because if you advise an MRI and comes out normal, you have an explanation to give. So what would you do next?
Yeah, that is when, as I said, that is what happens, a temporal pallor or a slight pallor. I don't do an OCT first for those patients. I go back and, review that patient's history and case sheets thoroughly. Generally, some drug somewhere, even the tobacco alcohol is so common, and some drugs somewhere. So that is when I do a new, if I can get a clue, I send the patient over to that consultant to stop the drug or whatever, modify the drug or look at it that way. And I send for fields next to see
Fields
what is
perhaps the most important too, because many of these bilateral visual field, they will not cause any pupil issue, so you will not get any RAPD, and fields will give you a definite clue. And there, if you have something obeying the vertical midline, it need not be a hemianopia, it need not be a proper quadrant, but if it is obeying the vertical midline, immediately think that you're justified in imaging.
Yeah, fields will also tell you whether you're looking at a compressive cause or whether you're looking at a metabolic or toxic cause. That's what I do. I send for a fields and then. Yes, PIO and frankly, I have come across PIONs in the ICUs mostly. I have come across 2 or 3, or maybe not many, but in PIONs in the ICUs. So only then after some time I've got the patient in the OP to actually see. By the time they were all in optic atrophy and I could not actually see the face practically, but theoretically PION is ischemic, so they have very steep cut borders and central is affected, whereas optic neuritis, the whole battery of field effects are possible. So that's the
MRI
what
can
the-
help in the acute phase. If you do an MRI and you ask the radiologist to look for diffusion restriction. Diffusion restriction in the posterior part of the optic nerve will be there in PION, but it's there only in the acute phase. Later it will not be there.
But
that is one way to distinguish.
and you can do fields in the non-arthritic type. This is how they have that is from the literature I am saying. In the non-arthritic type, when the patient is walking into your OP, you can look at fields and have a clue, because it is central, it is ischemic. Basically the field is ischemic.
Thank you, Dr. Lathika. Our next speaker is Dr. Neena. Dr. Neena will talk to us on the phantoms in the brain.
Thank you all, and thank you, Lathika, for this opportunity. So we've seen that the patient comes to your OPD with defective vision, and you have examined the patient, and there's nothing wrong in the ocular examination. That's when you start thinking out of the box. Is it something behind the eye that I have to focus on? So the slides are not moving. Yeah, so no financial interest. So I'll start with some interesting cases, because otherwise the theory is going to be very monotonous and repetitive. So this was a 70-year-old male who came to us with defective vision of both eyes. He has diabetes, he's hypertensive. So like Natasha was saying, this is the kind of scenario. He's 6'9" in the right eye, 6'12" in the left eye. Near vision is N8 in both eyes. Now, color vision is normal, but slow response. So you'll only get that response if you do it yourself. Otherwise, you'll miss this. Pupils were brisk, no RAPD. Anterior segment shows some immature cataract. So can you attribute all this to the cataract? So that's the question. So we have to sometimes take 5 minutes in the history. So when the patient comes to you all the way after multiple repetitive consultations elsewhere, patient is symptomatic. So you do that extra 5 minutes of history taking with the patient, ask what's really wrong. So then he tells that I'm missing letters when I'm reading newspapers, or I'm not able to see on one side. So when we ask the patient to read the Snellen's chart, we find that he's missing letters on the temporal side, and his color vision is a little slower response than normal. So these are some things we have a clue on. So when we look at the fundus, it could be anybody's take. It looks obviously normal. It doesn't look much abnormal to me. So what are we going to do next? So now this patient has reasonably good vision. So definitely we will go in for other tests. So again, OCT is not the first thing I would do. A visual field is what I do. But I just wanted to say first thing, if you have an OCT, you can do an OCT. You're not very sure, some temporal thinning here. You don't know whether this is attributable to the defective vision. But if you look at the GCL, it will tell you a little better. It will give you a better idea. You can see here, I don't know if it's visible to you, an arrow has been put. You can see that there is some thinning in both this side as well as this side. So there is some nasal thinning in the ganglion cell layer. You look at the absolute values also, you can see that there is reduced values in both the nasal areas. Okay, so but then again, that itself is not conclusive. You have to do a visual field, because definitely that will give you the clue. So what are you seeing here? This is a bitemporal hemianopia. Obviously more in the left eye. So again, so now you know why he was concerned, and he's having bitemporal hemianopia. And what is the next investigations you would do? You have to image this patient, and that is what we found. We found he had a large cellular mass which was compressing the chasm. It was a pituitary macroadenoma, and the typical snowman sign you can see here. So this is very easily picked up. But if you just brush it off and send the patient saying that, you will miss the entire lot, and the patient will obviously go without a diagnosis and may come back later with optic atrophy when it is too late to intervene. So next is this another 54-year-old male with no comorbidities at all, But here the complaint is sudden onset of defective vision of the right eye since 1 day. Okay, so that history is very important. So vision, when you look at it, it's perfectly normal, 6, and 6. Anterior segment is normal, pupils are normal, color vision is within normal limits. But then he says, it started suddenly. So when you look at the disc, the left eye is almost normal. The right eye, there is some fibrous tissue on the disc. But to me, it didn't look like an active, kind of thing. It was probably there for a long time. And otherwise, there was no signs of inflammation in the eye. So again, we did an OCT, some amount of temporal borderline thinning in the RNFL, but I wasn't very sure about it. But this was done by someone else and came back to me. So the full field 120 dash was done. And what does it show? You can see that there is a right homonymous hemianopia. Okay, so now when this kind of a patient comes to you, there is a hemianopia and a sudden loss of vision. What do you think? It has to be an acute attack, isn't it? Something. Again, an MRI brain with orbits. So what do you see here? You can see this here. So you can see that there are ischemic changes. He had an infarct in the left side of the brain. So again, an occipital infarct can present you only with defective vision, may not have any other neurological deficit. So you may be the first one who picks you up. So before you send to the neurologist, don't shy away from doing your neurophthal workup and then send to the neurologist, because then he may be able to help the patient better, and this may progress. He may get another infarct. So you have to be very prompt and active in your investigations. Okay, so this was a left occipital infarct, and so history was very important in this. So another interesting case was of a 29-year-old male, a healthy male. In fact, he is an avid gym goer with no systemic comorbidities. Came to me saying that he's having some left-sided vision loss after his morning workout. So again, vision is normal, 6 and 6 vision, anterior segment, pupils, fundus, everything is normal. So when we look at the fundus also, it's normal. But then I asked him a little bit, what did you do in the morning that, you had this blurring of vision? So he tells me that he's addicted to gym. He does a lot of weightlifting, and he's like, if he doesn't work out a day, he gets, he gets cranky and all that. So he does a lot of lifting heavy weights. So that was the thing which I got from the history. So when we did the RNFL, nothing much, maybe a borderline RNFL in the right eye. But then I did a fields. Okay, so that is when I found that there was this beginning of a superior right quadrantinopia, superior quadrantinopia, and that is when I thought maybe he's developing a stroke. So this was something. So you can see that is symmetrical in both eyes, in the right eye as well as left eye. So a left superior quadrantinopia he was kind of developing, and he was persistent that he's having some problem. Mainly he was complaining of the left eye because the temporal field. So he had again an infarction in the parieto-occipital cortex. So how did this happen? So I was very curious. I sent him to the neurologist. They did a DSA, and he was having a right vertebral artery dissection. How did this happen? Again, I was curious. So then the neurologist he told me probably this constant heavy lifting, and he was also doing some sort of keeping a lot of weights on his neck. So there was hyperextension of the neck, and this was leading to a vertebral artery dissection, leading to thrombosis and a cerebrovascular accident. So we have to counsel these patients very carefully, because he was addicted to gym, and I had to tell him a lot. You have to stop all this. You can do aerobic exercises and limit this heavy weightlifting, because it's causing problems to your health. So that is the thing. That's the way we go about diagnosing this. So this was a 64-year-old lady, again multiple comorbidities, diabetes, hypertension, dyslipidemia, came to us with defective vision of both eyes of 5 days duration. Vision was very poor here. Again, counting fingers close to face in both eyes and less than N36. Pupils normal. Anterior segment showed some nuclear sclerosis, cataract, nuclear NS 2 to 3. So then my PG was telling it could be because of the cataract. No? So I said, no, why look at the near vision? You definitely will have better near vision in these kind of patients, because nuclear sclerosis really doesn't produce this kind of vision loss. And she's saying 5 days duration. No neurological deficits. So again, field was something which I would like to do here, but she has very poor vision. So sometimes OCT can help you. It's not that OCT is not shouldn't be put aside. It's very useful investigation. So you can see here there was some RNFL thinning here, but the left eye, but this eye was normal. But if you look carefully in the OCT, you can see there is some amount of localized thinning in this area as well as this area. So that's when I thought again, if she was able to do a field, there could have been some hemianopias. That could have been the beginning of a hemianopia, basically on the right side. So probably she would have had a left homonymous hemianopia. So then we did a CT brain, then there was a hypodensity suggesting infarction of the right occipital cortex again. So again, history is very important. Spend that extra 5 minutes with your patient to take the history, and most often that will help you in deciding, giving a clue what she could be having and help you in doing the right investigations. So this is case 5, a 68-year-old male, diabetic, hypertensive, hyperthyroid, blurring your vision of 2 months. Vision was 612, N6 right eye, 624, N10 in the left eye. Everything else was normal. The anterior segment, some early lens changes. Posterior segment showed small crowded disc, but other than that, there was no pallor or anything. RNFL didn't give me much clue. I did a field straight away. So what is this we are seeing? Bilateral superior altitudinal defects. So is the patient having AION? So that's what the first thing which I thought, but there are no disc changes. So it cannot be an anterior ischemic optic neuropathy. So is it a bilateral PION? I was wondering, but then I knew that it's quite rare and I have to image this patient. So what did we find? We found that there was bilateral occipital lobe infarction, especially at this area, at the calcarine fissure, at the inferior lip of the calcarine fissure, which corresponds to the superior field. So when you have a symmetrical infarction in the inferior lips of the calcarine fissure, it can produce bilateral superior altitudinal defects. That's a rare situation, but you keep that in mind if you find a symmetrical altitudinal visual field defect. So similarly, if you have an upper lip of calcarine fissure lesion, you can produce an inferior altitudinal visual field defects. So I don't know if I have time. So again, this was, so sometimes you may get these kind of juxtaposed patterns. Okay, this is called checkerboard pattern on visual fields. So this patient came to us again with defective vision. This kind of patterns, don't say the patient has not done the fields properly. If the patient is complaining of a defective vision, please do image. There could be multiple infarcts. Okay, so that's why you're getting one quadrant anopia in superior part and then in the inferior part, or there may be a beginning of a hemianopia. So I'll just give you an overview. So the important thing to remember in the visual pathway is that your left visual field corresponds to the right calcarine fissure. The hemifield will correspond to the right calcarine fissure and vice versa. And the lesions are, we all know the kind of lesions that we get. If you have anything in the optic nerve, it produces monocular vision loss. Anything in the chiasm, it produces bitemporal hemianopia. But remember, sometimes you can have an encasing lesion of the chiasm, like the circle of Willis is there. So aneurysmal compression from outside can sometimes produce nasal hemianopias, though not typically binasal. If you have binasal, I would first rule out glaucoma, because typical symmetrical binasal field defects are very rare. Then anything beyond the chiasm is retrochiasmatic. It produces a homonymous hemianopias, and as you go towards the cortex, it becomes more congruous with macular sparing. So a little clues how to differentiate between the various types of hemianopias or quadrantanopias. Suppose you have a quadrantanopia and you want to know whether it's a temporal or parietal radiations which are involved. How do you differentiate? So one interesting thing that you can do in your OPD is look at the ipsilateral pursuits, because the ipsilateral pursuits are generated from the ipsilateral posterior parietal cortex. So if they are intact, you are probably dealing with a temporal lobe problem. If they are absent, it's a parietal radiations which are involved. And also the type of quadrantanopia. Superior quadrantanopia, it's temporal, and inferior it is parietal. So similarly, hemianopias also can be differentiated. So I don't know whether I should touch upon this because Dr. Rohit Saxena will be talking in detail about it. But just a word is that if you, after doing all these investigations, if you don't find anything wrong, and by certain characteristics and mannerisms of the patient, you think that this is a functional vision loss, that's a different totally ball game. That's a condition in which the patient is counterfeiting a disease with a benefit in mind. So it is a benefit either for escaping some services or for some monetary gains or for some other insurance purposes. So it can be a positive simulation that is simulating a disease, or it can be a negative simulation that is denying a disease. Rarely you can even have a hysterical conversion reaction patient or a hysterical patient, in which case the patient strongly believes that he or she is ill. So you have to be very careful. That's when you have to bring in a psychiatrist or a psychologist into the picture. Never confront the patient and say, no, you're feigning it, because that will jeopardize your entire management. So you have to believe that patient is telling the truth first and prove yourself wrong. So that's how you go. So I think Dr. Rohit is going to cover all this. So I don't want to touch upon this. So just, some important things that you can do is some subjective and objective tests. I'll just finish this. So I'm not going to talk about this much because Dr. Rohit Saxena is going to tell us about it. So there can be different types. There can be simulation of visual field defects, night blindness, and all that. So summarize, never give the impression that you're suspecting the patient is malingering. Okay. So choose easy and efficient tests, and never confront the patient saying that no, you are feigning this, because then your patient is going to be uncooperative and will never come back to you. So it's logical for us to imagine or to think that the patient is telling the truth and prove ourselves wrong. So that would be the right way to go about it in these kind of patients. So thank you.
Thank you, Nina. That was a very exhaustive presentation. I'm sure Rohit sir will tell us more about functional visual loss, but still, maybe your top choice of 2 tests you can just
So first, the easiest, it all depends on the severity of the vision loss. Suppose the patient is coming to you and saying that he's bilaterally blind. Okay, so like a patient comes to you and says no clear vision, he's having. One easy test that you can do is, if you have a large mirror in your OPD, most of us have a mirror, isn't it? So you can take it out and ask the patient to, you just stand in front of the patient or sit in front of the patient at 1 meter's distance and ask him to just look straight. He'll say, I can't see anything. I said, okay, no, you can't see anything, but just look straight. Rotate the mirror from side to side. Okay, rotate the mirror from side to side. So what will happen is, there will be saccadic eye movements. So something like an optokinetic nystagmus will happen. Okay, you cannot suppress that. Any patient who has vision enough to look at the mirror, he cannot avoid his own reflection in the mirror. He has to keep his eyes straight. So if you look straight and in the mirror, you look at the movements of the eyes. So if you are able to generate that, saccadic eye movements, something like an opaque will happen. You know he's at least has vision to look at the mirror. So that is one easy test, especially for patients who say bilaterally blind. So that's one thing. Then for malingerers, a lot of children sometimes come, like they will say they can't read 624, 618 kind of vision. Then the easiest thing is to do a fogging with a high plus and minus without them knowing that you're fogging. Or you do a binocular test like stereopsis. Okay, ask them to read the stereopsis chart. So if they are able to read, let's say 60 odd seconds of stereopsis, then you know they have to have some vision to have that much of, to read that near vision chart. So these are some things that we do. Then if you are still not able to do, you do all the investigations including electrophysiological tests and then MRI and then look at it, what is happening. But before you complete these kind of investigations, please don't label anything as because sometimes we have patients with real organic disease, picked up after all these things.
Yes. So thank you once again, Nina. That was great talk. You want to say something?
Just a fun question to the audience. What is the risk factor for CVA due to hyperextensibility of the neck in the ladies here? Anybody? Any situation in which you would hyperextend your neck for a prolonged period and you're at risk of CVA due to vertebral artery dissection? Not a facial. Facial you don't do hyperextension. No, you're on the couch. Hair spa is a big risk because if you're doing hyperextended hair spa and hair wash in the basin, then you should tell them, please, no, I don't want that.
No, there is a tip I can.
Parlor stroke. Your neck.
So there's a tip for that hair spa also. I I asked them to put that there is some. If you ask, they will give you something to keep there, which will reduce this risk to a considerable degree. Yeah, cushioning. So next, we have the most very coveted talk of the session. It's a keynote address by Dr. Rohit Saxena on face-to-face with functional visual loss, unforgettable lessons from my experience.
So thank you very much for the opportunity to be here, and I mean, a keynote experiences, these are all shared experiences. Nina's given some very nice tips, and these are, I think, all our common experiences. So I'll just run through some of the things that we have come across, and we've talked about a lot of these which could present as functional vision loss, and as has been discussed, it could be because of a monetary benefit. Sometimes it could be just unintentional, and often in children it's just the pressure of the stress or an exam or avoiding or a situation or trying to get away from some person or an environment. So as has been mentioned before by Dr. Nina, you can't be judgmental about anybody or any behavior, and you need to actually work with them. The presentations can be unilateral or bilateral, severe loss of vision or just mild blurring or just even field effects, and the patient may just refuse to say that I'm not able to see a particular place. And it sometimes may be associated with a lot of other physical changes or physical activities like blepharospasm. Some kids can simulate all kinds of strabismus, nystagmus. So a lot of presentations are possible. The key thing is to try and find out what is the precipitating event or the stress inducer that the child has. Of course, as has been mentioned before, you must rule out an organic pathology. Actually, it would be unethical to label a patient with some or any pathology as a malingerer, not only because of the fact that you're missing an organic disease, but because it does involve some amount of social and family pressures, and again, judgmental behavior from adjacents. And like, in the late, they'll start saying कि इसके दिमाग में कुछ problem है. So those are not kind of, identifiers we'd like to have, particularly with children or those who are in a uncomfortable situation. And the aim is to trick the patient into demonstrating some normal visual function. Unfortunately, by the time they've come to us, many of them have been through a lot of the tricks that we have in the armamentarium, and they already know how to, trick us with them if, they are for a particular benefit. So it's not always easy, and you need to go step by step. So first, I'll run through some of the cases that we've had. So this was a 65-year-old retired teacher. In fact, he was one of my earlier teachers. He just came with difficulty in near vision for 1 year. He just was not satisfied with the multiple number of glasses he was using, and the essential thing was that he had been through a lot, progressives and all that. So we also said that, again, must be a refractive error. What else? Nobody's done a great refraction. Let's get him to do a dilated refraction and all that. So we just started to get him read, and we realized he was just shuffling his head a little to try and get an abnormal head posture and read. So his reading was N6, but he was not very comfortable repeatedly changing his head, and he kept saying that I'm a little uncomfortable with my glasses. This was his fundus, and again, he was about 70 or so, was labeled normal earlier. So again, what do you say? Always referred to as a difficult patient, and as is the want, in at least in our center, and I'm sure a lot of neuro-ophthalmologists, when they don't know what to do, they think that the neuro-ophthalmologists have nothing else to do is time. And we are going through so many pentacams and OCTs and what have you, and these guys have nothing better to do. They sit and chat with the patient all day. So you might as well discuss what's wrong with the gentleman, and he's a difficult patient and they'll sort it out. So our visual fields, these are Goldman perimetry. These are actually a confrontation perimeter done and put on paper. So nowadays we don't have Goldman perimetry because we don't have a good perimetrist who can do it. But essentially this is like charting out whatever is seen. So this is what the patient could see, and obviously all this area is gone. So the patient actually had a bitemporal hemianopia. And a lot of neurological and neuro-ophthalmological fields can be picked up by a good confrontation test, and probably that's all you need. And he had a large pituitary macroadenoma, as can be evident by the field. So the important thing to remember is never label a patient as a malingerer or daft or whatever have you. It's very important to actually go into all the issues. A lot of these diseases which have been discussed here have been labeled as functional vision loss, a lot of them being maculopathies. We have these small kids coming to us with, or young kids about in their early teens who come to us with mild temporal pallor. Now it's a constant fight with us, with the retina people, who keep sending us and saying, mild temporal pallor. And I said, no, there's a bit of maculopathy to it. He says, no, it's mild temporal pallor. It's your job. Whatever you want to do with the kid. So in those are the conditions where I would feel a multifocal ERG may have a role to play, where we are picking up these are times of competition, and all children, even mild visual dysfunction would come to us. So early pickup of a heredomacular degeneration may be possible with an MFERG. Of course, after you've ruled out everything else that may be responsible. Now, this was a 25-year-old person who came with working in a private firm, presented with low vision in both eyes for 8 years. He was essentially coming for a disability certificate because he wanted to apply for a government job. He had fairly significant high refractive errors. He was about 2/60, 3/60. He had poor vision with nystagmus. So again, unfortunately, because people don't know what nystagmus really is, this is what... I mean, of course, that was not nystagmus, but everything else was normal. His pupils were normal. Obviously, with his vision that he was claiming to be, it was not possible to do fields. We re-refracted, cycloplegic. There was no significant refractive error. But again, there was still no significant improvement. We wanted him to get a VER. The pattern, he was just not looking at it. The flash VER was normal. So again, it's easy to fetch a pattern VER. Not easy for a flash, because the light you cannot really avoid if your head is straight. Even if you close your eyes, the flash is usually bright enough to get you an adequate response. But the pattern, easy to fetch. Smart people can just look through, don't look at the pattern, or look a little elsewhere, or just relax, and they're not seeing through that pattern. So it's important to know what investigation to order, because an affected pattern VER, and then you're again struggling and saying that there is some neurological defect in the patient. This patient was definitely, obviously malingering for a clear cause. So you need to put all the story together. He had a reason to do that, and that's why. And again, like I said, the nystagmus, you need to record and see what he was doing. A 13-year-old girl, sudden loss of vision in the right eye, referred as right optic neuritis, received 5 doses, no change, PL positive in one eye, PR inaccurate in the other, everything else normal. Again, the most important thing to pick up: unilateral vision loss, large retinal lesions, and beyond, right up to the chiasma, anything, you are going to have an afferent defect. A pupil is the most sensitive test to pick up optic nerve lesions. Of course, large macular lesions will also be affected, but then you're going to, by that time an RAPD has come up, you'll be able to see a fair amount of changes on the retina. So everything was done in the child, because young girls, sometimes not easy. Everything was normal. Likely malingerer, how do we confirm? Again, we did all our tests first to confront her. We did everything binocularly so that she feels that, yes, I'm seeing through the better eye always. The key test was stereopsis. often, thankfully, I would say for us, many centers do not, and non-pediatric ophthalmologists do not keep stereo tests. So that's one test the kids or patients are not aware of. So a stereo test is a very helpful test. They think every test that we are doing is being done binocularly, and they're able to know. So when they're able to pick up stereopsis, when we're able to pick up good stereopsis, we know that they were malingering. The patient is malingering. It was discussed, and of course, we got to know that the child was because of exams. This 15-year-old girl, bilateral loss of vision, PL positive, PL negative. The PR kept varying. Every once in a while, some other field would get affected. The pupils, anterior segment, posterior segment was normal. Now, this was the girl. So we brought her to a nice crowded ward that we have. We made her sit, and then we asked the patient's relatives to go, and then we kept on calling her. And that's what you have to observe, what she's up to. And this was her avoiding her bumps. She seemed to nicely navigate through the door, and then the relatives will come and then she starts laying her hands and trying to search for objects. And then you keep the
और जो बच्चे ने सुनाया कि ना मैं मम्मी तक टीचर बोले सुनिए बता तो नहीं किया बुलाया बता फिर हम सर बोला कि बच्चा मेरी तो पिटाई कर
These are ways of
अचानक से चला गया सब तुमने सारा बता दिया था फिर क्या हुआ
possible attention-seeking behavior. Suspect when the visual functions are not collaborating with a thorough examination, signs and symptoms are visible. The challenge is to demonstrate one or other normal visual function with objective evidence, and again, not to miss organic causes. More severe and more one-eyed the visual complaint, the easier it is to diagnose a functional vision loss. Again, you have a patient, you can make them wait in the waiting area, just watch them. They're wearing sunglasses in your room because they don't want you to see how they are looking. And these are ways, of course, pupil testing acuity at varying distances. You have a single letter optotype. So the patient is not knowing if it's a subnormal vision. The patient does not know what is the vision I tested earlier. So sometimes if we've had patients who come for medical because of whatever jobs, for UPSC jobs and all, so they know that they need to have 618 vision to get 40% handicap certification, not more, not less. Less, they don't qualify for handicap certification. More, they get ruled out for one or the other particular job. So 618 is a very beautiful cutoff which they have learnt and they have been, taught and fed. So again, do optotypes of single letter optotypes on a screen so that they don't know, and then vary the distance. So you need to trick the patient into not knowing what he is doing. Then stereo acuity, again, varying, has 60 seconds of arc, but at 618. Little unlikely, of course, correspond that with the near vision, but these are tests. Mirror test was talked about. You can even do it unilaterally. Again, as was being mentioned, it's very difficult to avoid. You have a large mirror in front and there is nothing else but just like preferential looking tests for children. It's been devised because it's very difficult for us to not look at an object with structure, with contrast. So every once in a while he'll look away and then come back and look at himself for a second or two and then look away. So these are very, very good tests. Fogging, of course, you have the patient read binocularly and suddenly slip in a high power lens in front of the seeing eye, and if he continues to read and does not, so they'll read a couple of letters and then they realize that something is not correct, and then they'll suddenly stop. So these are, you just need to be and then while he's reading a chart, you put a pen or something in the middle. So if you're reading binocularly, you'll be able to look around and not require head movements. If he's doing head movements just because the pen is in the middle, he's looking at it uniocularly. Otherwise, he's able to look around. One eye is able to look around and still continue to read. So duochrome test, stereo acuity test, all these are very good ways of picking unilateral vision loss and sometimes bilateral loss also. This was 30-year-old female who was referred with as diagnosed as amblyopia, malingering, sudden loss of vision both eyes, 10 days, significant vision loss, was prescribed glasses outside, not wearing, everything else was normal. You can see suddenly she comes to us, cycloplegic, high hyperopia. So is it ametropic amblyopia? Red flags, recent loss of vision. Obviously, that's not going to happen in ametropic amblyopia. Some pain, the history appeared to be reliable, the pupils were sluggish. when we did an MRI, because nothing was fitting in place, there was enhancement, the MOG was positive. Again, is despite the setting being like a malingerer, we still come across pathology. So again, always be careful. Do not overdiagnose malingering. As Dr. Nina said, say you're going to find out an organic cause and then be proved wrong to yourself. You need to have a comprehensive examination. Do not really reveal your suspicions. Notice behavior, personality, posture. Examine the patient separately, not in front of the family, because then they will be on their guard. And obviously have an eyewitness in case of issues in the front, because you can be accused of anything in today's medical legal world. And of course, you need to discuss gradually. You need to discuss with close parents. You may need assistance and help with the psychiatrist or a complete team. Be gentle, and of course avoid being confrontational or trying to be very aggressive in your diagnosis, or even telling the parents or associates. So sometimes it's a very catch-22 situation, how much you want to tell the relatives, because sometimes the source of that conversion reaction or the problems may be with the person who's come with the patient. So all these things are very gentle and sometimes really take a lot of time and understanding to try and get the patient to come back to normal or realize that they have normal vision. So thank you very much for the opportunity, and it was a pleasure to be here.
So it was really an eye opener talk by Rohit sir, and such simple things, such seemingly simple things that make a huge difference to our lives and somebody else's too. So this is one area where it is not knowledge that matters, but the way we use it also matters very much. And we have to be sensitive and sensible at the same time in dealing with these complex situations. It's not just medical situation. We may have to extend our helping hand beyond the patient to their families to cope with the person. Usually what happens is our responsibility in getting to the diagnosis itself tires us, but actually the journey of the patient and the family starts there, and it's another journey where we cannot handhold them, but we can always bring in people who can do that. So once you have a functional visual loss, it is your responsibility to diagnose and to refer them to proper people who can handhold them further and counsel them further, so that is where treatment begins. So we are open to questions. We have 5 to 10 minutes more. So any aspect anybody would like to discuss further, we can always take questions. Okay, then we can yes. Actually, I make my PGs do pupil cycle time. I mean, it's not very bad. I mean, we can do it. Can be easily detected. We can do it. Yeah, we don't need to do the entire. We extrapolate. We do for 10 seconds or 20 seconds, still it is enough. We can always do the arithmetic. So can we, sir, anything else? So we...
It's great that this was discussed. Functional vision loss is a very and much neglected. And it's, as Dr. Lathika was talking about, we handhold and meet. My voice is out now. So it's very important that we gently handhold and transfer them. These are patients who are crying out in need. Their abnormal behavior is a request that somebody please help me. So we've been busy in our OPDs and we see so many patients, and these are actually uncomfortable patients who, it's very easy to be judgmental that you have nothing and you're coming and crowding up my OPD and this is so much of my time. But these are patients really against your parents or trying to have a different path. So telling this to the parent may actually worsen the the situation the child is in. So more than the child, actually it is the parents who require counseling and require better understanding of their children. We are so used to putting in round pegs and square holes that we don't realize that every child, every life is different and to be celebrated as well. So that's what it is. It's sometimes a very big challenge, particularly among children, understanding and trying to be sensitive to their needs. So
I have a question. I think in many Western countries there are like specific protocols as to how to deal with. I mean, who to inform, and like there are like child services and this thing. So, do we have anything like that in the pipeline, or why can't AIOS actually take up something like that? Because I think child abuse is a very talked about, and it is rampant throughout the country, and I think somebody needs to talk about it and bring it to the light.
it's very nice that we have this functional middle class. I hope next time we have some child abuse. It is difficult to pick up, and there is nothing, no guidelines. So it's that's where you are. You don't know the legal aspect where you are, and you do not know what to do for the child. And eventually we are all sending this over to psychiatrists, psychologists to handle it, and they probably would be in a better position to know what to do and how to do and the medical legal aspect of it. But I guess we're practicing in the field, and we are seeing children, particularly possibility of this issue here, there, and try and yes, more difficult to handle, more complex and
after cataract surgery, we have had some patients coming from orphanage. They have been enjoying a lot of privileges so long. After such a many number of years, we are doing cataract surgery, and then they don't want to lose those privileges because they have good vision. They wouldn't.
So I think we are coming to the end of our time also. I thank everybody who has stayed back and made this session worth it, even on the last day of the conference. Thank you so much to every one of you.